Think about this. By 2040, the number of people living with diabetes worldwide is projected to hit a staggering 642 million. That's a huge shift in global health.
It really is.
And one of the most devastating complications that can arise, diabetic foot ulcers. That's the focus of our deep dive today. We're here to, make sense of it for you.
Exactly. We're diving deep into diabetic foot ulcers, drawing from the comprehensive resource, Wound Care Essentials. Practice Principles. Our guide really is a chapter specifically on diabetic foot ulcers by Peter Andrew Crisologo and his colleagues.
Right. And our goal is pretty simple. To give you the essential understanding of DFUs, why they're so serious, what sets them in motion, who is at greatest risk, and what can actually be done to prevent and treat them. We're trying to cut through the complex medical jargon here, deliver the core insights. The chapter itself aims to clarify the significance, prevention strategies, how to sort of understand and assess these wounds.
The critical role of pressure reduction, definitely, and the available treatment options.
Yeah. Okay. So where do we start?
Well, to get a handle on this, we'll start by looking at the big picture, the growing diabetes epidemic. Then we'll break down the fundamental causes of these foot ulcers.
Makes sense.
After that, we'll talk about how to identify those who are most vulnerable. And finally, we'll explore the various approaches to, keeping ulcers at bay and treating them when they do occur. So let's get into it.
Let's do it. The sheer scale of the diabetes problem is, well, it's hard to ignore. Back in 2015, the global estimate was around 415 million people with diabetes.
Already a huge number.
And now that projection for 2040 is 642 million. That's a massive increase in, a relatively short time. And it's a similar story in the U.S., right?
Absolutely. In 1990, it was about 6.2 million adults with diabetes in the U.S. By 2017, that number had ballooned to 30 million.
Wow.
And what's critical to understand here is the direct link between the rise in diabetes and the inevitable increase in diabetes-related complications.
Right, like these foot ulcers.
Exactly. Conditions like diabetic foot ulcers become much more common as more people live with the underlying condition. This is why understanding DFUs isn't just some niche medical topic. It has really broad implications. It's also important to think about the concept of diabetic foot syndrome, or DFS.
Okay, DFS. What exactly is that?
Well, think of DFS as a sort of collection of foot problems. They're either caused by diabetes or made worse by it, and they ultimately lead to ulcers, infections, and unfortunately the risk of amputation.
So what's included in DFS?
Key players are peripheral sensory neuropathy, that's nerve damage affecting sensation, and peripheral arterial disease, PAD, which messes with blood flow.
Okay.
But there are other factors too, things like limited joint movement, changes in the foot's actual structure, issues with bone metabolism, even problems with balance. And you also have things like a weakened immune response, sometimes poor nutrition, and Charcot-neuroarthropathy that affects the bones and joints of the foot itself, all under the DFS umbrella.
So it's really not just one thing. It's a combination of factors making the foot incredibly vulnerable. And the impact on healthcare must be enormous.
It is, yeah. Diabetic foot problems are a major reason people with diabetes end up hospitalized. They account for a significant chunk of their hospital days.
Really?
Oh, yes. And the rate at which DFUs pop up annually is substantial. What's particularly worrying is that this rate shoots up dramatically in people who've had ulcers before or have other serious conditions like kidney failure.
And infection. That sounds like a really dangerous turning point.
Absolutely. Getting an infection in a DFU is a critical event. It often means hospitalization, could lead to amputation, and definitely increases the likelihood of future problems. The infection rate in DFUs is alarmingly high, around 60%.
60%? That's huge.
It is. And even after someone is discharged from the hospital for a DFU, the chances of being readmitted within the next year are surprisingly high, maybe up to 50%. So the key takeaway here isn't just that these ulcers are common, but once they happen, they create this kind of vicious cycle of complications. It's incredibly difficult and costly to break that cycle, which really highlights why prevention is so critical.
Those numbers really paint a stark picture. It underscores how serious this is. Are there resources out there for people, dealing with diabetes and its complications?
Yes, absolutely. The American Diabetes Association, the ADA, is a fantastic resource for patients, their families, healthcare professionals too.
What kind of info do they have?
They offer a wide range of information on diabetes management, diet, exercise, understanding complications like this. Their website is ada@diabetes.org, and they have a helpline too, 1-800-DIABETES.
That's definitely a helpful resource to know about. And the outcome we're obviously trying to prevent is amputation.
Precisely. Diabetes is the leading cause of lower limb amputation in the United States. The numbers are significant, truly, and the risk of amputation for someone with diabetes is, well, it's 15 to 46 times higher than for someone without diabetes.
That's staggering.
It is. And tragically, after a first amputation, the risk of needing another one is also very high, maybe 9–17% within the following year. We also see that these amputations disproportionately affect certain populations like Hispanics and African Americans.
So, with that understanding of the growing problem, let's dig into what actually causes these ulcers and who is most at risk. What are the main things that put someone in danger?
Well, the number one risk factor for developing a diabetic foot ulcer, or even needing an amputation, is having a history of a previous ulcer or amputation,
So, past problems are the biggest predictor.
by far. That piece of information in a patient's medical history is incredibly important. It's also crucial to remember that the underlying issues that lead to DFUs, the neuropathy, the PAD, they're usually not reversible and tend to get worse over time.
Okay, so once you've had an ulcer, you're at a much higher risk. What are the typical ways these ulcers actually start? How do they form?
Generally, foot ulcers in people with diabetes develop through three main pathways. First, ill-fitting shoes.
The shoes again?
Yep. These are often injuries from low but constant pressure over a long period. Second, ulcers can form on the parts of the foot that bear weight. That's due to repetitive moderate pressure and also the rubbing or shear forces on the skin.
Okay, weight-bearing areas. And the third?
The third is penetrating injuries, like stepping on something sharp. These cause ulcers from a single instance of high pressure. Understanding these different ways ulcers can start is really key, both for treating existing ones and figuring out how to prevent new ones.
That makes sense. Chronic low pressure, repeated moderate pressure, or a sudden high pressure injury. Now, we mentioned neuropathy earlier as part of DFS. How does that nerve damage specifically lead to foot ulcers?
Right. Peripheral sensory neuropathy is really central to the development of DFUs. Diabetes affects not just the sensory nerves, the ones for feeling, but also the motor nerves controlling muscles and the autonomic nerves for automatic functions.
Okay.
With sensory neuropathy, the body's natural warning system, pain, becomes impaired. This leads to what we call loss of protective sensation, or LOPS.
LOPS, loss of protective sensation.
Exactly. Essentially, that crucial ability to feel pain or discomfort in your feet is diminished or completely gone. So someone with LOPS can injure their foot without even knowing it's happened.
So they might step on something sharp, or their shoe might be rubbing really badly and they just won't feel it?
Precisely. And the problems don't stop there. Motor neuropathy causes the small muscles within the foot to weaken and shrink, to atrophy.
Okay, so the muscles get weaker.
Yes. And this creates an imbalance in the foot's mechanics. It often leads to deformities like claw toes, where the toes curl under, and also misaligned joints at the base of the toes, the metatarsophalangeal joints. Plus, it's common for people with diabetes and neuropathy to have limited movement in their ankle and toe joints. That adds to the problem.
And what about autonomic neuropathy? How does that contribute?
Autonomic neuropathy affects those involuntary functions, like controlling blood flow and the function of sweat and oil glands in the skin. This can lead to abnormal blood flow patterns in the foot, shunting blood away from the skin sometimes, and it causes a reduction in sweating and oil production, resulting in skin that's very dry, cracked, and much more easily injured.
So you've got the lack of feeling, the muscle weakness and deformities, and the dry, fragile skin.
Exactly. It's a really dangerous combination. If you have a foot with structural problems, dry skin, and a reduced ability to feel and respond to injury. It's actually quite rare to see a patient with a diabetic foot ulcer who doesn't have some degree of sensory neuropathy.
So early detection of neuropathy seems incredibly important then. How can healthcare professionals identify who's at risk early on?
Absolutely. Early detection is just crucial for preventing DFUs and amputations. Healthcare providers need simple, effective screening tools. There are a couple that have been developed. The Healthy Feed Screen, which can help spot skin changes even before a diabetes diagnosis sometimes, and the 60-second screen for the high-risk diabetic foot. And interestingly, one study showed a really remarkable reduction in amputations, around 68%, when the 60-second screen was implemented.
Wow, 68% reduction. That's a huge impact from just a quick screening. What are some of the more detailed ways to check for sensory neuropathy?
There are several methods. A thorough physical exam is key, of course. Then there's testing the ability to feel vibrations and assessing pressure sensation using something called Semmes-Weinstein monofilaments.
Monofilaments.
Yeah. These tests are generally pretty affordable, quick to do, And don't involve anything invasive. It's usually a good idea to demonstrate any test on the patient's hand or arm first, so they know what the sensation should feel like in an area that likely has normal feeling.
Right, so they know what to expect. Let's talk about the vibration test. How is that done?
Okay, for vibration perception, we commonly use a 128 hertz tuning fork. You tap the tuning fork to make it vibrate, and then place the base on a bony part of the foot, like the big toe joint, the knuckle. You then ask the patient if they can feel the vibration and to tell you when it stops. Typically, someone without nerve damage should feel a vibration for more than 15 seconds. Less than that suggests neuropathy.
And VPT testing, you mentioned that uses a specific device.
Yes, VPT stands for Vibration Perception Threshold. It's a way to measure the ability to feel vibrations using a device called a VPT meter. Now, the device itself can be a bit more expensive and less portable than a tuning fork, but it gives a precise numerical reading that can make it easier to interpret the results and reduce differences between different examiners. A small rubber tip on the device is placed on a bony point, and the intensity of the vibration is slowly increased until the patient feels it. Not being able to feel it even at a higher setting, like over 25 volts, is a sign of LOPS.
Got it. And then there are the Semmes-Weinstein monofilaments. I understand those are quite specific tools.
They are. The Semmes-Weinstein monofilament test uses a set of thin nylon fibers. They're designed to bend when a very specific amount of pressure is applied.
Like a calibrated pressure.
Exactly. A 10-gram monofilament is the one often used to check for protective sensation in the feet of people with diabetes. It's really important to use calibrated monofilaments from a reliable source, because the actual force they apply can vary between brands. Also, these filaments can wear out with repeated use, which could lead to inaccurate results down the road.
So how is the 10-gram monofilament test actually performed? What does that look like?
Okay, so the test involves touching the 10-gram monofilament to 10 specific spots on each foot.
10 spots?
Yep. On the bottom of the first, third, and fifth toes, on the bottom of the knuckles of the first, third, and fifth toes, the metatarsal heads, on the middle of the inner and outer sides of the bottom of the foot, on the heel, and one spot on the top middle of the foot.
Okay.
The patient should be lying down or sitting, feet bare, toes pointing up. First, you show them what it feels like by touching it to their arm or hand. Then they close their eyes, and you gently press the filament straight onto each of the 10 spots until it just bends into a C shape. Hold it there for about 1 second.
Just 1 second.
Yeah, and it's important not to slide it across the skin. You ask the patient to say yes every time they feel it. You test all 10 spots, but in a random order, and vary the time between each touch so they can't guess.
Right.
And if there's a scar or a callus or any dead tissue at a testing spot, you test right around the edge of that area. If the patient can't feel the filament at any of these spots, it indicates LOPS.
And if LOPS is present?
Then it's absolutely vital to teach the patient how important it is to check their feet every single day and how to protect them from injury, since they can't rely on feeling pain.
That's a very precise way to assess sensation. It really highlights the need for careful examination. Now, let's switch gears a bit and talk about blood flow. How does peripheral arterial disease, or PAD, increase the risk of diabetic foot ulcers?
Okay, yeah. Getting enough blood flow perfusion to the tissues is absolutely essential. It's critical for healing if an ulcer develops and for preventing infections that could lead to amputation. In people with diabetes, PAD often involves multiple blockages, typically in the small and medium-sized arteries below the knee, the infrapopliteal vessels. So unlike PAD and some other conditions that might mainly affect larger vessels, in diabetes, it often hits both the smaller and larger blood vessels in the lower leg and foot.
And that increases the risk.
Significantly. It significantly increases the risk of developing foot ulcers, getting infections in those ulcers, and ultimately, the need for amputation. Poor blood flow just hinders everything.
We also hear about microvascular changes in diabetes. How do those relate to PAD and foot ulcers? Is that different?
Well, it's related. There are a couple of main ideas about these microvascular changes, the changes in the tiniest blood vessels. One theory is that high pressure and increased blood flow in these tiny vessels can directly damage their lining. This leads to thickening of the vessel walls and makes the capillaries more fragile.
Okay, more fragile.
Yeah, and this fragility could partly explain why infections might spread more easily in people with diabetes. Another idea is that autonomic neuropathy, which we talked about earlier, can indirectly affect these small blood vessels. It can cause blood to be shunted away from the skin, making the skin more susceptible to injury, and also hindering the healing process if an ulcer does occur.
So how do doctors evaluate the blood flow in a patient's foot? What do they look for?
A thorough evaluation involves several things. First, asking about symptoms. Does the patient have pain when walking that goes away with rest that's claudication? Do they have pain in the foot, even when resting? Have they had previous surgeries to improve blood flow?
Okay, the history is important.
Very. Then, during a physical exam, the clinician will look for signs of poor circulation. Things like changes in skin temperature as the foot cool, color changes, does it get red when hanging down or pale when elevated? Is there loss of hair on the legs and feet? Is the skin shiny? Feeling the pulses in the lower extremities is also a really key part of the exam.
And are there specific tests?
Yes. According to guidelines, measuring the ankle brachial index, or ADI, is an important initial test for PD. It compares blood pressure in the ankle to the arm.
ABI.
However, in some people with diabetes, especially if they've had it a long time, the arteries can become stiff due to calcification.
Ah, so the test isn't accurate then.
It might not be. If the ABI reading is very high, say above 1.3, it often means the arteries are stiff and not easily compressible. In these situations, and also in people with advanced diabetes or end-stage kidney disease, the ABI might not give a true picture of the blood flow.
So what do you do then?
In those cases, a toe brachial index, measuring pressure at the toe, should be used instead, as the toe arteries are less likely to be calcified. Or, a consultation with a vascular surgeon might be necessary. More specialized tests that measure blood pressure at different levels in the leg can also help pinpoint where blockages might be.
Okay. Moving on to the skin and nails, which seem like obvious areas where problems could start. What should healthcare providers be looking for there?
You're right. Careful examination of the skin and nails is vital. You're looking for subtle, early signs that an injury might be on its way.
Like what kind of signs?
Things like areas of high pressure, maybe redness that doesn't go away quickly, cracks in the skin, especially the heels, maceration, that skin getting soft and white from too much moisture, often between the toes, blisters or small breaks in the skin called fissures.
And calluses?
Yes, definitely watch calluses. Any discoloration or bleeding under a callus can be a sign of trouble brewing beneath the surface. Patient education is really crucial here. Everyone with diabetes should be taught how to check their own feet regularly. It's a key prevention strategy.
Makes sense. What about the nails?
Nails that are deformed or very thick can press on the skin underneath or on the adjacent toes and lead to ulcers, subungual ulcerations. Common nail issues we see in people with diabetes, like fungal infections, onconia ecomycosis, or ingrown toenails, onchonicocryptosis, might seem minor.
But they're not, right?
Not in this population, no. They can unfortunately lead to more serious issues like skin infections, cellulitis, bone infections, osteomyelitis, nerve damage, and even problems with blood flow. Everything is interconnected.
And what about the muscles and bones of the foot? How do deformities and problems with the foot's mechanics contribute to ulcers?
Well, as we touched on with neuropathy, ulcers in people who can't feel properly often develop because of repetitive pressure and rubbing shear forces. This can happen on the bottom of the foot from walking or from shoes pressing on the top or sides. It's important to understand that there isn't one specific pressure level that's dangerous for everyone. It's more about how much pressure is applied over time in someone who can't feel it. And diabetes can significantly change the way the foot works, the biomechanics, especially if there are already deformities present.
You mentioned intrinsic minus foot earlier. Can you explain that again and how it causes problems?
Certainly. Motor neuropathy can cause those small intrinsic muscles inside the foot to weaken and waste away. That's the intrinsic minus foot. This muscle weakness creates an imbalance.
An imbalance how?
It often leads to deformities like claw toes, where the smaller toes curl downwards, almost like a claw. And it causes increased downward pressure at the metatarsophalangeal joints, the knuckles of the toes, where the toes meet the foot.
Okay. And that leads to ulcers.
It can, yes. Ulcers can then develop under these prominent metatarsal heads because of the increased pressure and friction, especially from shoes. This is made worse if the protective fat pad under these bones has also thinned out, which often happens with diabetes and aging.
So the cushioning is gone, too.
Right. And as the toes become more and more deformed and the joints at the base of the toes sort of dislocate upwards, sublux dorsally, the metatarsal heads can actually be pushed down and almost through the sole of the foot. The tips and tops of the toes and the area under the metatarsal heads become major high-pressure zones. And because of the lack of sensation, ulcers can form very easily there.
What about joint mobility? You said that can be affected too.
Yes, limited movement or limited joint mobility in the ankle and the joints in the toes has been linked to a process called soft tissue glycosylation.
Glycosylation.
Yeah, it's where excess glucose molecules attach to proteins in tissues, like the Achilles tendon and the tissues around the joints, making them stiffer, like caramelization
Oh,
almost.
God. Okay, so they get stiff.
Exactly. And this reduced movement, especially in the ankle and the big toe joint, can lead to higher pressures on the forefoot when walking. Interestingly, some people with diabetes who have an intrinsic minus foot might look like they have a high arch.
But they weren't born with it.
Often not, no. It's frequently due to the weakening of a specific muscle on the inner side of the foot, the abductor hallucis muscle, which normally helps support the arch.
And then there's Charcot-neuroarthropathy, which sounds like a very serious condition.
It is. It's a severe complication affecting the muscles, nerves, and importantly, the bones and joints of the foot and ankle in people with diabetes, particularly those with significant neuropathy.
What happens in Charcot foot?
Essentially, Charcot-neuroarthropathy involves the weakening of the bones. This leads to fractures, joint dislocations, and collapse of the foot structure, often without the person realizing it because they can't feel pain. These changes can cause major deformities, especially on the bottom of the foot, creating bony prominences in areas of very high pressure that are extremely vulnerable to ulceration. It can lead to what's often called a rocker bottom foot deformity.
Wow. So from loss of feeling to poor circulation and these major changes in the foot's structure, it's a really complex set of risks. Let's talk about infection now. How common and how serious are infections in diabetic foot ulcers?
Infections are indeed very common and very serious, a real game changer. The majority of people with DFUs, maybe around 56%, will need treatment for a soft tissue infection at some point.
More than half.
Yes, and alarmingly, about 20% of those will go on to develop an infection in the bone underneath, which is called osteomyelitis.
Osteomyelitis, okay.
It's absolutely vital for healthcare providers to be on high alert for any signs of foot infection in people with diabetes, because the usual signs and symptoms, pain, redness, warmth, swelling, can be less obvious or blunted, sometimes even absent.
Why is that? Why are the signs less obvious?
It's largely due to the effects of high blood sugar, hyperglycemia, on the immune system. It impairs the body's inflammatory response.
How exactly does high blood sugar weaken the immune response?
Well, high blood sugar can interfere with the body's defense systems in several ways. It can affect the production of important immune chemicals like cytokines. It can disrupt the function of key immune cells like neutrophils and macrophages that fight off bacteria. And it can even impair the body's ability to repair damaged tissues effectively.
So the body just can't fight back as well.
Exactly. This weakened immune response makes it much harder for the body to fight off infection once it takes hold, and makes the person more susceptible in the first place.
Given that wounds often have bacteria just living in them normally, how do doctors tell the difference between that simple presence of bacteria and a true active infection that needs treatment?
That's a really important distinction, you're right. Many open wounds, especially chronic ones, will have bacteria living on their surface colonization even if they aren't truly infected.
So swabbing isn't always helpful.
Routinely taking swabs from the surface of wounds that don't show other signs of infection, like increased redness, warmth, swelling, pus, or pain, is generally not recommended. Those results can be misleading.
Okay, so when are cultures needed?
When cultures are needed because infection is suspected, it's best to get a sample of the deeper tissue in the wound, not just a surface swab.
Deeper tissue, how is that done?
For mild to moderate infections, a good technique is to take tissue samples, maybe by curettage, from the base of the ulcer after any dead tissue has been cleaned away, debrided, and ideally before starting antibiotics.
And for severe infections?
In cases of severe infection, the priority is to start empiric antibiotics, ones that cover a broad range of likely bacteria as quickly as possible. Cultures should still be obtained, perhaps from deeper tissue or blood, but treatment shouldn't be delayed.
What if bone infection, osteomyelitis, is suspected?
If osteomyelitis is suspected, a bone biopsy, ideally guided by imaging like X-ray or MRI, is considered the gold standard. That allows you to culture the bone itself to identify the specific bacteria causing the infection.
And does the depth of the wound matter for infection risk?
Yes, very much so. The depth of the wound is actually one of the strongest predictors of infection risk. Wounds that are deep enough to reach or probe to bone have a much, much higher risk of both soft tissue infection and bone infection compared to more shallow wounds.
What about biofilm? We hear a lot about that in chronic wounds generally. Does it play a big role in diabetic foot ulcers?
That's a good question. Biofilm is basically a community of bacteria that forms a protective slimy layer, and it's definitely been linked to wounds that don't heal well in general.
So it makes wounds harder to treat.
That's the idea. However, the evidence for how common biofilm is specifically in diabetic foot ulcers that don't heal, well, it's still somewhat limited. Some smaller studies have found biofilm in a portion of chronic wounds, maybe 23–60%.
But not always.
Right. It's not clear if it's present in all or even most non-healing DFUs. Importantly, we don't yet have strong evidence from human studies showing a clear difference in biofilm presence between DFUs that eventually do heal and those that don't. Also, there isn't yet solid proof that specific anti-biofilm treatments consistently improve healing or prevent infection in diabetic foot wounds in humans. This is definitely an area where we need more research to really understand the role of biofilm and how best to tackle it if needed.
Okay, so that's still developing. When someone comes in with a diabetic foot ulcer, what kind of imaging might be helpful? What do doctors look for?
When someone with diabetes has any open wound on their foot, it's generally a good idea to get an initial x-ray. The main reason is to check for signs of bone infection, osteomyelitis, or maybe a foreign object.
So x-ray is the first step.
Usually, yes. Plain x-rays are readily available and inexpensive. However, they might not show bone infection early on. If the wound has been open for several weeks, or if bone can actually be felt when the wound is gently examined with a sterile probe, the probe-to-bone test,
Right.
then further investigation might be needed even if the initial x-rays look normal. More advanced imaging like MRI can be more sensitive for detecting osteomyelitis. But as we discussed, the most accurate way to diagnose a bone infection is still that bone biopsy where the tissue is cultured and examined histologically.
Given how complex diabetic foot ulcers can be, with all these factors and neuropathy, PAD, infection risk, biomechanics, it really sounds like a team approach to prevention and treatment would be the most effective way to go. What does a multidisciplinary framework look like?
Absolutely. A team approach is essential. First off, it's crucial to evaluate each person's individual risk factors and then categorize them based on how likely they are to develop ulcers or need an amputation.
Stratifying risk.
Exactly. Unfortunately, many healthcare providers don't routinely check the feet of their diabetic patients, or they tend to think of everyone with diabetes as being equally at risk. This can lead to some people not getting the preventive care they really need, while others might receive treatments that aren't necessary for them.
So risk classification systems are helpful.
Very helpful. Systems like the one from the International Working Group on the Diabetic Foot provide a structured way to categorize patients based on their specific risk level presence of neuropathy, PAD, deformity, previous ulcer, etc. Regular foot exams should help with this classification, guiding how often and how intensive the preventive care should be for each person.
And are specialized clinics helpful for managing these high-risk patients? Does that make a
Oh,
difference?
definitely. Research has consistently shown that specialized clinics that focus specifically on the diabetic foot can significantly reduce the number of amputations, sometimes by 50% or more, and also lower hospitalizations for high-risk patients.
What makes them effective?
These clinics often bring together different specialists, maybe podiatrists, vascular surgeons, infectious disease doctors, endocrinologists, wound care nurses, orthotists, who are all focused on preventing and treating foot problems in people with diabetes. They can coordinate care effectively. Professional organizations have also developed clear guidelines for preventive measures.
The chapter also mentions a spoken hub model. What does that involve? How does that work?
The spoken hub model is basically a strategy for organizing care across a region. It uses community-based wound care centers as the spokes, the first point of contact for initial assessment and treatment of most wounds.
Okay, the local centers.
Right. Then the more complex and challenging cases, the ones needing more specialized care or potentially limb salvage surgery, are referred to specialized tertiary centers, the hubs. These are often larger hospitals or academic centers with advanced capabilities.
So it directs patients to the right level of care.
Exactly. It helps to differentiate between general wound care and the highly specialized care needed for the most severe cases. There's also increasing interest in the idea of short periods of intensive inpatient treatment for chronic wounds that just aren't getting better with standard outpatient care.
Intensive inpatient care, like what?
Well, this could involve things like pretty tight blood sugar control, focused nutritional support, interventions to maximize blood flow, maybe intravenous antibiotics, and potentially repeated surgical cleaning, debridement in the operating room. The goal would be to stabilize the wound quickly and achieve definitive wound closure, maybe with a graft.
It sounds like good communication and coordination between all these different healthcare providers is absolutely key.
Absolutely critical. The treatment of chronic wounds can sometimes be complicated by the fact that there are many different types of wound care providers out there, each with their own specific training and areas of expertise. This really highlights the value of having wound care settings where different specialists can easily work together, communicate, and create a single, comprehensive treatment plan for the patient. Co-located care is often ideal.
Prevention is obviously the ideal scenario, avoiding the ulcer in the first place. What are some of the most important aspects of basic foot care for people with diabetes?
Regular foot exams by a podiatric physician or another trained healthcare provider are essential. They can identify new risk factors early and help prevent problems from developing.
What happens during these exams?
These professionals can provide routine care like trimming nails safely, managing calluses and corns appropriately. They can also regularly check the patient's shoes and any insoles they might be using to make sure they're still fitting well and doing their job.
And education.
Yes, these visits are a great opportunity to reinforce important self-care education. Reminders like avoiding walking barefoot, even indoors, keeping the skin properly moisturized, but not between the toes, and, crucially, checking their own feet every single day for any changes, cuts, blisters, or red spots. Protective footwear and insoles can also be prescribed, and their effectiveness should be checked regularly.
Let's talk more about these special shoes and insoles, therapeutic footwear. Who typically qualifies for them?
Okay. In the U.S., people with diabetes who are considered at high risk for foot problems and who are enrolled in Medicare Part B might be eligible for coverage under Medicare's therapeutic shoe bill.
What makes someone high risk for this?
To qualify, a person generally needs to have diabetes and at least one of several specific conditions. Things like a previous amputation of the foot or part of the foot, a history of foot ulcers or pre-ulcerative calluses, also significant nerve damage, neuropathy with evidence of callus formation, or a foot deformity that could cause problems, or documented poor circulation, PAD.
And what does Medicare usually cover under this bill if you qualify?
Medicare Part B typically covers one pair of either custom-molded shoes along with inserts, or one pair of extra-depth shoes each calendar year, as long as the patient meets the criteria and has significant diabetic foot disease. They also usually cover additional sets of inserts each year, either heat-molded or custom ones. In some situations, shoe modifications might be covered instead of inserts.
Extra depth shoes, what are those exactly?
Extra-depth shoes are a key part of preventive care. They generally have a higher and wider toe box area compared to regular shoes. This extra space is important because it can accommodate custom or prefabricated inserts or orthotics, and it can also fit various foot deformities without rubbing or causing pressure points. Properly fitted shoes along with supportive insoles can significantly reduce pressure on vulnerable areas of the foot.
Are custom molded shoes always necessary? Or are extra depth shoes often enough?
That's a good question. Custom molded shoes are made specifically from a mold or scan of an individual's foot. They can be very helpful, even necessary for people with severe deformities that just can't be accommodated by standard or extra depth shoes.
But they're probably more expensive.
They're generally more expensive, yes, and they take time to make. For many people with less severe issues, a good pair of well-fitting athletic shoes, comfortable walking shoes, or standard therapeutic shoes that have extra depth is often sufficient, especially when combined with the right kind of insole or orthotic.
Okay.
It's worth noting, though, that sometimes the decisions about these shoes and insoles are made by technicians who may not have a deep understanding of the underlying biomechanics or medical research. And there's often a lack of systematic follow-up to see if the chosen footwear is actually effective in preventing re-ulceration for that specific patient.
So what does the research actually say about how well therapeutic footwear works? Is there good evidence?
Yes, there's a growing amount of evidence from various studies that shows therapeutic shoes and insoles are beneficial for high-risk patients with diabetes. These studies often compare outcomes for people using these specialized shoes to those who just wear their own regular self-selected shoes.
And what do they find?
Consistently, the rates of getting another ulceration are much higher in those who don't use appropriate therapeutic footwear. People who do receive and use therapeutic shoes and insoles typically have a significantly lower risk of re-ulceration, maybe a 2- to 4-fold reduction in some studies.
That sounds pretty good.
It is a significant benefit. However, It's important to be realistic. Even with these preventive measures, a substantial number of high-risk patients, maybe 24% to 50%, may still develop another foot ulcer within a year or so. Prevention is key, but it's not always foolproof.
Are there differences in how effective different types of insoles are, like custom versus off the shelf?
Some studies have looked into that, but the results have been a bit mixed. For example, one study didn't find a significant difference in ulcer rates over 2 years between people wearing their own shoes and those wearing shoes with either custom cork inserts or prefabricated polyurethane insoles.
Okay.
However, another study suggested that custom footwear that was actually adjusted based on a detailed analysis of how someone walks using in-shoe pressure measurement in a gait lab might be more effective than traditional custom footwear, especially when you factor in how consistently people actually wear them.
So customization might matter.
It might. Overall, the evidence is definitely leaning towards therapeutic shoes, and insoles being better than regular shoes for prevention in high-risk individuals. And there's some indication that custom options, including newer types designed to reduce shear forces, or those made using computer-aided design and manufacturing, CAD/CAM, might offer additional benefits in reducing the risk of getting another ulcer. Structured prevention programs that include providing custom shoes and insoles have also been shown to significantly reduce ulcer incidence over longer periods, like 3 to 5 years.
Now, what about patient education? It seems like that would be a really important part of preventing problems, teaching people what to do.
Yes, it's long been thought and intuitively makes sense that educating patients is a key part of preventing DFUs. This usually involves giving people detailed information about diabetes, its effects on the feet, and how to manage foot care over time.
But does it work? Does education alone prevent ulcers?
Well, that's where it gets a bit nuanced. A major review of research back in 2004, a Cochrane review, found only weak evidence that education by itself significantly reduces foot ulcers and amputations in high-risk patients.
Really? That's surprising.
It was a bit. However, the same review did suggest that having more knowledge about foot care can lead to positive changes in self-care behavior in the short term. So the general consensus now is that ongoing education and reinforcement, especially targeted toward those at high risk, is likely helpful and necessary, probably in combination with other preventive measures for improving outcomes over the long run. It's probably not enough on its own, but it's still important.
What are some of the challenges in providing effective education? Why might it not be enough on its own?
There are several significant challenges. Many people with diabetes, whether they currently have foot ulcers or not, have other issues that make self-care difficult. Problems with their vision, for instance. Difficulty using their hands due to arthritis or neuropathy, manual dexterity issues, or limited movement in their joints, making it hard to bend over and reach their feet.
Physical limitations.
Exactly. For instance, studies have found that a significant number of patients who develop ulcers literally cannot see the bottom of their feet or easily reach them. And some have significant vision loss from diabetic retinopathy.
So what's the solution then?
In these cases, education and training in foot care absolutely must also involve the patient's spouse, family members, or caregivers, whoever is helping them. And repetition is key. Repeating key messages regularly and having all members of the healthcare team, doctors, nurses, podiatrists, educators, reinforce these messages consistently is crucial for helping patients and their families truly understand and implement protective foot care practices.
A more recent approach seems to be monitoring foot temperature at home. How does that help prevent ulcers? That sounds interesting.
Yes, at-home temperature monitoring is a newer concept that shows promise. It can help high-risk patients, particularly those with neuropathy, identify early signs of inflammation or tissue injury in their feet before an actual ulcer develops.
How does temperature indicate injury?
Inflammation, which is the body's response to injury or stress, causes localized increases in temperature. Because nerve damage can mask the usual warning signs of pain and discomfort associated with inflammation, these small injuries or areas of high pressure can go unnoticed. Checking foot temperature regularly, comparing spots on both feet, can pick up these subtle temperature differences.
And has this been shown to work?
Some studies have shown really encouraging results. They suggest that using daily at-home foot temperature assessment can significantly reduce the risk of foot complications like ulcers and Charcot events in high-risk individuals, maybe a 3 to 10-fold reduction compared to standard preventive care alone.
Wow, that's a big difference.
It is. The benefit is that it provides an objective, measurable sign that something might be wrong, prompting the person to reduce activity or seek medical attention before the skin actually breaks down and an ulcer forms. It empowers the patient with early feedback.
That sounds like a really promising tool for prevention. Now, shifting gears again, when an ulcer does unfortunately develop, how are the characteristics of the wound and how severe it is assessed? Are there standard ways to classify them?
Yes, there are several systems used to classify diabetic ulcers. One well-respected and widely used one is the University of Texas, or UT, classification system.
The UT system, what does it look at?
The UT system is valuable because it considers not just how deep the wound is, the grade, but also whether there's infection present and whether there's ischemia, meaning poor blood flow, a stage. It looks at depth, infection, and vascular impairment.
And why is that combination important?
Because those three factors, depth, infection, and ischemia, are very important predictors of the outcome, particularly the likelihood of needing an amputation. Studies using the UT system have shown pretty clearly that the risk of amputation increases significantly as wounds get deeper, and especially if infection or significant PAD is also present.
Is that the only system?
No, another system known as the Meggitt-Wagner classification has also been widely used for many years. It primarily grades based on depth. However, it doesn't consistently incorporate infection, other than deep bone infection, or ischemia into its grading, which can make it a bit less helpful for predicting outcomes or guiding some treatment decisions compared to the UT system.
So thinking about assessment, what are the key things that should be evaluated when looking at a diabetic foot ulcer, according to major guidelines like those from the American Diabetes Association?
The ADA recommends a really systematic approach to wound assessment. It starts with the history, asking about any specific trauma or injury that might have caused it. How long has the wound been there? Is it acute or chronic? Have the signs or symptoms been getting better or worse? What treatments have been tried before? And importantly, what worked or failed?
Okay, so the history of the wound itself.
Yes. And also assessing the patient's overall health. How well is their blood sugar controlled? What other medical conditions, comorbidities do they have that might affect healing, like kidney disease or heart disease?
And the physical examination of the wound.
The clinical assessment should carefully identify several key things. First, any signs of ischemia or poor blood flow, like we discussed, cool skin, poor pulses, color changes. Second, any signs of infection, either in the soft tissues around the wound or potentially involving the bone. Third, accurately measuring the wound length, width, and especially depth. And finally, documenting the appearance of the wound bed itself.
What details about the appearance are important?
Things like, is there callus around the edge? Is there devitalized tissue like slough, which is yellowish stringy stuff, or eschar, which is hard black dead tissue? Or is there healthy pink or red granulation tissue, which is good? What kind of drainage is there, if any amount? Color, odor, is there any exposed tendon or bone? All these details help determine the wound status and guide treatment.
And what are the basic principles, the core elements that guide the treatment of diabetic foot ulcers once they're assessed?
The ADA treatment algorithm, based on consensus reports, really highlights 6 key essentials for effective DFU management.
6 essentials. Okay, what are they?
1. Debridement, removing dead or unhealthy tissue early and often. 2. Reducing pressure on the ulcer, offloading. 3. Maintaining a moist wound healing environment with appropriate dressings. 4. Treating any infection that's present. 5. Correcting ischemia, improving blood flow if there are significant problems below the knee. And 6. The ultimate goal, preventing amputation.
Okay, let's break those down. The first one, debridement, removing dead tissue. What are the different ways that's done for DFUs?
Sharp debridement, which involves using sterile instruments like a scalpel or curette to precisely cut away devitalized tissue, is really considered a cornerstone of DFU treatment.
Why is it so important?
It has several benefits. It removes dead tissue that harbors bacteria and hinders healing. It reduces the bacterial load in the wound. It gets rid of harmful inflammatory enzymes called proteases that build up in chronic wounds. And it often creates a fresh, bleeding wound bed, which can stimulate the healing process. Diabetic ulcers often have that hard rim of callus around them, and it's really important to remove all of this callus and any other non-living tissue to get clean wound edges and also to take pressure off the underlying wound.
Is sharp debridement always possible or the best option?
Usually it's preferred, if possible. But if sharp debridement isn't feasible, maybe due to patient factors, lack of trained personnel or setting, or if the patient has significant PAD where cutting could compromise blood flow further, then other methods might be considered. These include enzymatic debridement, using topical ointments that contain enzymes to break down dead tissue, or autolytic debridement, which uses special dressings to keep the wound moist and allows the body's own enzymes to slowly liquefy the dead tissue.
Does debridement need to happen repeatedly?
Yes, Often ongoing debridement is needed as the wound heals, because devitalized tissue can reaccumulate. Research actually suggests that more frequent debridement, perhaps weekly, is associated with higher healing rates compared to less frequent debridement.
Are there times when sharp debridement in a clinic setting might have limitations?
Yes, definitely. Sometimes controlling significant bleeding can be difficult in a clinic. Managing pain effectively might be a challenge. And it's not a fully sterile environment like an operating room. These factors can sometimes limit how thoroughly the dead tissue can be removed in a single clinic visit.
So is debridement in the operating room better sometimes?
Debridement done in an operating room, OR, can overcome these limitations. You have better anesthesia, better lighting, better instruments, and a sterile environment. This allows for a more aggressive and complete removal of all unhealthy tissue. There's also a concept called excisional debridement, where the entire wound, including a margin of the surrounding tissue, is surgically removed down to healthy bleeding tissue. In the OR, this extensive debridement can sometimes be immediately followed by procedures to definitively close the wound, like using stitches or applying a skin graft or skin substitute.
And what about maggot therapy? That's a less common treatment, isn't it?
It is less common, but it has its place. Maggot debridement therapy, or MDT, involves using medical-grade, sterile larvae of specific species of flies, usually green bottle flies, to clean the wound.
How does that work?
It's usually considered for removing non-viable dead tissue in patients who might not be good candidates for surgical debridement, perhaps due to medical reasons or preference. Studies have shown that maggot therapy can be very effective, sometimes even faster than conventional methods, at removing necrotic tissue and reducing bacteria. The maggots secrete enzymes that liquefy the dead tissue, which they then ingest, without harming the healthy surrounding tissue.
How are they applied?
The sterile larvae are applied directly to the wound and kept contained within a special breathable dressing for a few days, usually 2-3 days per cycle. Then the dressing and maggots are removed. It might take several cycles. While it might sound unpleasant, it can be a very effective and selective form of debridement.
Okay. The next key step you mentioned was reducing pressure or offloading. Why is this so vital for neuropathic ulcers specifically?
Reducing pressure and also shear forces, the rubbing forces on the foot, is absolutely crucial for healing neuropathic ulcers. It's often considered one of the most important, yet sometimes unfortunately neglected, aspects of treatment.
Why is it so easily overlooked?
Well, because people with neuropathy can't feel the pain from the pressure, they often continue to walk on the ulcerated area without realizing they're constantly re-injuring it and preventing healing. You can put the most advanced dressing on a wound, but if the patient keeps walking on it, it's unlikely to heal.
So the goal is to take the pressure off.
Exactly. The goal of offloading is to effectively reduce the pressure on the ulcer itself, while ideally still allowing the person to be as mobile and functional as possible, although that's often a trade-off. There are various methods to achieve this, and the best approach really needs to be tailored to the individual patient and the location of their ulcer.
Does the method matter?
Yes. Generally speaking, methods that are more restrictive, that limit activity more, tend to lead to less overall activity and therefore better healing rates. Patient education is also really important here for compliance. They need to understand clearly that the ulcer is caused or aggravated by pressure and that every unprotected step they take can delay or prevent healing.
What are some of the common ways to offload a diabetic foot ulcer? What options are there?
There's quite a range of options, varying in effectiveness and restrictiveness. It can range from simple measures like complete bed rest, or using a wheelchair, which are very effective but often impractical long-term, or using ambulatory aids like crutches or a walker to reduce weight bearing. More specific devices include things like applying felted foam padding around the ulcer to redistribute pressure, using special shoes like half shoes that remove pressure from the forefoot or heel, standard therapeutic shoes with appropriate insoles, custom-made shoe inserts or orthoses, custom splints or braces, and various types of prefabricated cast walkers or boots.
The total contact cast, or TCC, is often mentioned as being very effective, maybe the gold standard. Why is that?
Yes, the total contact cast, TCC, is widely considered the gold standard for offloading plantar neuropathic ulcers, ulcers on the bottom of the foot. It works by intimately conforming to the shape of the lower leg and foot, distributing weight-bearing forces over a larger surface area, thereby significantly reducing the peak pressure directly on the ulcer site.
How is it applied? Does it need special skill?
Applying a TCC properly does require a trained and experienced healthcare professional. It involves applying a cast, usually fiberglass, with minimal padding, directly to the leg and foot, ensuring it's very closely molded, especially around the contours of the foot and ankle. It typically covers the toes as well, providing protection. Because it fits so snugly, it minimizes movement within the cast and effectively transfers weight away from the forefoot and midfoot.
How often is it changed? And how effective is it?
TCCs are usually changed every 1 to 2 weeks, sometimes more often if there's a lot of drainage or concern about infection. Numerous studies over the years have shown that TCCs can achieve very high healing rates for plantar neuropathic ulcers, often healing them within 6 to 8 weeks, and consistently demonstrating higher healing rates compared to other less restrictive offloading methods in comparative trials.
What's the main advantage?
A big advantage is that it essentially enforces compliance with offloading. The patient can't easily remove it, so they have to keep the pressure off the ulcer when they walk. It's similar in principle to how a cast helps a broken bone heal by providing rest and immobilization.
Are there downsides to TCCs?
Yes, there are disadvantages. They can be heavy, bulky, and sometimes hot, making them uncomfortable. They can make daily activities like bathing difficult. Walking can feel awkward. And crucially, TCCs should not be used if there's a suspected or active infection in the wound, as they prevent regular wound inspection and drainage. They also require expertise to apply correctly to avoid complications like rubbing or new pressure sores.
Removable cast walkers, or boots, seem like they might be a more convenient option for patients. How do they compare to TCCs in terms of effectiveness?
That's right. Removable cast walkers, RCWs, are often preferred by both practitioners and patients because they're much easier to apply and remove. Several studies have actually indicated that RCWs can be comparable to TCCs in their ability to reduce pressure on plantar ulcers if they are worn correctly and consistently.
So compliance is the issue.
Compliance is the big if. Because they are removable, patients might take them off more often than they should, reducing their effectiveness. However, RCWs do address some of the drawbacks of TCCs. They allow for easier management of swelling, edema, and the use of compression dressings if needed. They permit regular inspection, cleansing, and treatment of the wound with advanced dressings. And because the foot can be checked frequently, concerns about reduced blood flow, which can sometimes be an issue with a tight TCC, are generally less of a problem.
What are other advantages of removable walkers?
They are relatively inexpensive compared to custom devices. Many have replaceable insoles. They don't require specialized training for application like TCCs do. And as mentioned, they can be easily removed by the patient or clinician for wound assessment and debridement.
I've heard of an instant TCC. What's that?
The instant TCC, or ITCC, is a clever modification. It involves taking a standard removable cast walker and making it non-removable, usually by wrapping it with cast material or using strong plastic ties that the patient can't easily cut. The idea is to improve patient compliance with wearing the device.
And does that work?
Yes, studies have shown that this approach can significantly improve compliance and achieve healing rates very similar to traditional TCCs, while still allowing for removal in the clinic for wound care. It kind of offers the best of both worlds in some ways.
So is there one best offloading device?
Ultimately, no single offloading device is right for every patient or every ulcer. The choice depends on the ulcer location, severity, presence of infection or ischemia, patient factors like ability to comply and balance, and clinician expertise. Sometimes a transitional approach is used, maybe starting with an ITCC or TCC for initial healing, then moving to a removable device, and finally to therapeutic shoes and insoles for long-term prevention. Research comparing TCCs, removable walkers, and half shoes generally shows the highest healing rates with TCCs, but comparable outcomes between TCCs and non-removable cast walkers.
What about healing sandals and half shoes? When are those typically used?
Healing sandals and half shoes, often featuring a wedge designed to remove pressure from either the forefoot or the heel, can be useful in certain situations. They might be used for less severe ulcers, for people who genuinely cannot tolerate a TCC or a walker, or often as a transition after a cast or walker is removed, while the patient is waiting for their custom therapeutic shoes and insoles to be made. There's also a specific modification of a standard surgical shoe called the Carville Healing Sandal that incorporates molded plastizote to offload specific areas.
Are there specific types for after surgery?
Yes. Surgical shoes with a rigid rocker bottom sole are generally preferred for offloading after foot surgery. One common type is the wedge shoe, often used after forefoot surgery like bunion correction, to completely relieve pressure on the front of the foot. However, some patients find these wedge shoes difficult to walk in. They can sometimes cause pain in the opposite leg due to the altered gait, create instability, and they're generally not suitable for everyone, like those with ankle contractures or midfoot problems. Studies have also shown that patient compliance with wearing healing sandals tends to be lower compared to non-removable devices like TCCs.
And ankle foot orthosis, or AFOs, when do they come into play?
Custom-made ankle foot orthosis, AFOs, can be used for various complex foot and ankle conditions seen in diabetes, including managing Charcot fractures, stabilizing tendon injuries, and offloading certain neuropathic ulcers, particularly around the ankle or heel. One example is the Charcot Restraint Orthotic Walker, or CRW boot, which is a rigid custom-molded brace, often with a rocker bottom sole, designed to immobilize the foot and ankle and provide protection while allowing walking.
Are they common?
Custom AFOs, like the CROW, can be very effective, but are also quite expensive, and their fit might become problematic if the shape of the foot changes due to resolving swelling or ongoing Charcot activity. Less expensive, off-the-shelf AFO options are becoming more available, but might need to be replaced more frequently and may not provide the same level of customized support.
Okay, let's move on to some of the other therapies that are sometimes used in addition to debridement and offloading. What about negative pressure wound therapy?
Negative pressure wound therapy, or NPWT, is widely recognized now as a useful adjunctive therapy for many types of wounds, including diabetic foot wounds. It involves applying a controlled vacuum through a special dressing sealed over the wound.
How does it help?
It's reported to help wounds heal faster and promote the growth of healthy granulation tissue. The proposed mechanism involves removing excess fluid, reducing swelling, increasing blood flow locally, and physically stimulating the tissue through microdeformation. It can be used in both the hospital and outpatient settings.
Is it used for all DFUs?
Not necessarily. It's important to have a clear goal for using NPWT. Often, it's used primarily as a way to prepare the wound bed for definitive closure, like getting it ready for a skin graft, rather than being used all the way through to complete healing, epithelialization, on its own, although sometimes it is. Newer NPWT devices are smaller and more portable, making outpatient use easier.
I've heard about MPWT with installation.
Yes, that's a variation called MPWTI. Some devices can periodically instill fluids like saline or antiseptic solutions into the wound bed while still applying negative pressure. This might help to cleanse the wound and manage infection more effectively, especially in complex or infected wounds. This combined approach has shown some promising results in treating severe infections like infected joint implants or acute foot infections, potentially reducing the need for multiple surgeries or shortening hospital stays. However, the ideal type of solution to use, how long it should dwell in the wound, and the optimal duration of therapy are still areas being actively studied.
What about using electrical stimulation to help wounds heal? Is there evidence for that?
Electrical stimulation, or E-stim, is another adjunctive therapy where studies suggest potential benefits for accelerating wound healing. It might also help increase blood flow, perfusion, to the area and possibly enhance local cellular immunity.
What's the theory behind it?
The basic idea is that a wound disrupts the natural electrical currents that exist in intact skin. Applying external electrical stimulation might help to restore or mimic these natural currents, which could influence how cells involved in healing migrate and function. There's some evidence that certain types of E-stim, like T and S, can improve skin blood flow in diabetic patients and increase the release of growth factors like VEGF, which helps form new blood vessels. There's even some early research suggesting it might have some direct bacteriostatic effects, slowing bacterial growth, but more studies are definitely needed, especially regarding its use in infected ulcers.
Are there other adjunctive treatments that are being explored or used?
Yes, several others. Hyperbaric oxygen therapy, or HBO, where a person breathes 100% oxygen in a pressurized chamber, has been used for some time for difficult wounds. While many reviews have found the overall evidence supporting its routine use for diabetic foot wounds is not very strong or consistent, at least one high-quality randomized controlled trial did show a significant benefit in terms of healing and reducing major amputations. So it remains somewhat controversial, and more research is needed, especially looking at its cost-effectiveness, given that it's a relatively intensive and expensive treatment.
Anything else?
Other therapies that are being actively studied or used in some centers include things like topical application of growth factors like epidermal growth factor, EGF, or platelet-derived growth factor, PDGF, various advanced wound dressings designed to manage moisture or deliver active agents, skin substitutes, either biologic or synthetic, to cover the wound, and products derived from the patient's own blood platelets. The field is constantly evolving.
And antibiotics are obviously crucial when there's an infection, right?
Absolutely. When a diabetic foot ulcer is clinically infected, appropriate antibiotic therapy is essential. However, it's vital to remember that antibiotics alone are often insufficient without good fundamental wound care, meaning effective debridement and offloading. You can't just rely on pills to fix the problem.
How are antibiotics chosen?
Antibiotics should really only be used when there are clear clinical signs of infection. The initial choice is usually empiric, meaning based on the likely pathogens involved, given the severity of the infection and the patient's history. For mild to moderate infections in people who haven't recently taken antibiotics, targeting common skin bacteria like staph and strep, gram-positive cocci, is usually sufficient. More severe infections, or infections in patients who've had recent antibiotic exposure or hospitalization, might require broader spectrum coverage to include gram-negative rods and sometimes anaerobic bacteria.
Is there one best antibiotic?
Because the evidence comparing different regimens is limited, there's no single perfect antibiotic route of administration, oral versus 4, or duration of treatment that works best for everyone. Decisions are based on clinical severity, culture results when available, local resistance patterns, and patient factors. Bone infections, osteomyelitis, typically require a much longer course of antibiotics, usually at least 4 to 6 weeks, and sometimes even longer if infected or dead bone remains after debridement.
You also mentioned topical antiseptics and wound cleansers earlier. How do they fit into the treatment plan? Are they used often?
That's a great point. The importance of topical antiseptics and wound cleansers is sometimes underappreciated. They can play a valuable role in removing debris, reducing the bioburden, the amount of bacteria in the wound, and helping to prepare the wound bed for healing.
Are they safer than antibiotics?
They generally have a lower risk of causing systemic side effects or leading to widespread antibiotic resistance compared to systemic antibiotics. They work directly on the wound surface where they're concentrated, are usually well tolerated, and are widely available and relatively inexpensive. Common examples used in wound care include dilute sodium hypochlorite, DAC solution, dilute acetic acid, vinegar, solutions containing polyhexanide, PHMB, or dilute povidone iodine. These have been shown in lab studies to be effective against a broad range of microbes, including resistant strains like MRSA.
So they could be quite important.
Yes, given the growing global problem of antimicrobial resistance, optimizing the use of these topical agents might become increasingly important. They can be applied in various ways, simply used for washing or irrigating the wound during dressing changes, applied via saturated dressings that stay in contact with the wound, or even delivered intermittently or continuously via some NPWT systems, as we discussed with MPWTI.
What about surfactants?
Surfactants, which are basically detergents, are another category of topical therapy that might be underutilized. They work by helping to break up debris, biofilms, and prevent bacteria from sticking to the wound surface. They're used quite a bit in orthopedics, for example, to irrigate contaminated fracture sites. Something as simple as Castile soap has been shown to be well tolerated and effective, with one study in open fractures showing results comparable to using topical methotrexate antibiotic.
Interestingly, the chapter also discusses surgery not just to treat existing ulcers, but also potentially to prevent future ones. That sounds like a different way of thinking.
Yes, that's a really important point to consider, especially given the high recurrence rates of DFUs. The question is posed, can foot surgery actually prevent future ulceration? We know the high risks associated with ulcers that don't heal, amputation, chronic infection, osteomyelitis. And we know that even with standard preventive care like therapeutic shoes, ulcers often come back, maybe 30–50% recurrence within a year or two.
So how does surgery compare?
Well, in contrast, several studies looking at specific planned surgical procedures performed to address the underlying deformity causing an existing ulcer have reported very high rates of initial healing, like 91 to 100%, and relatively low rates of the ulcer returning at that same spot later on, maybe 0–39%.
So surgery might be better long-term?
It suggests that in carefully selected patients, surgery aimed at correcting the biomechanical problem, improving joint motion, reducing bony pressure points, correcting structural deformities may actually offer the lowest rate of reulceration in the long run. While we lack large randomized controlled trials directly comparing surgery to non-surgical prevention for preventing first-time ulcers, the evidence for using surgery to heal existing ulcers and prevent their recurrence is quite encouraging, and these procedures are generally safe and effective when done by experienced surgeons.
Can you give some examples of these types of surgical procedures used for ulcers?
Certainly. One common example addresses ulcers under the ball of the foot, often related to tightness in the calf muscle or Achilles tendon, which limits ankle dorsiflexion, bringing the foot upwards. This condition, called equinus, increases forefoot pressure. A procedure to lengthen the Achilles tendon, often done percutaneously with small incisions, can reduce this pressure. Studies have shown this can significantly reduce forefoot loading and lower the rate of reulceration compared to standard care like TCCs alone, especially for ulcers that haven't healed with casting.
Okay, Achilles lengthening. What else?
Another example involves ulcers on the big toe, often under the joint or on the tip, which are frequently associated with stiffness in the big toe joint, hallux, rigidus, or limitus. A surgical procedure called resectional arthroplasty, like a Keller procedure, involves removing a small portion of the bone at the base of the big toe. This effectively shortens the toe slightly and relieves pressure. Studies have reported that this can significantly improve healing rates and lower recurrence rates for these specific types of ulcers compared to just standard wound care.
But what about surgery just for prevention before an ulcer happens, like fixing a bunion?
That's an important distinction. Elective surgery for conditions like bunions, hallux valgus, or hammer toes in diabetic patients without a history of ulceration is generally not proven to prevent future ulcers. Such surgeries carry their own risks and should typically only be considered if the deformity is causing significant pain or functional limitation. However, these same types of corrective surgeries can be very effective tools for healing existing ulcers caused by those deformities and reducing the risk of them coming back.
Okay, that clarifies the role of surgery. Finally, the chapter really emphasizes how important it is to empower and engage patients in their own care. Why is that so critical?
Because diabetes is fundamentally a chronic, long-term, and complex condition that requires a tremendous amount of day-to-day self-management by the patient. Success really depends on their active participation. Therefore, the relationship between the healthcare provider and the patient is incredibly important.
How should that relationship work?
It really needs to be a therapeutic partnership, one that empowers and motivates the patient. Using appropriate, encouraging, and supportive language is key. How we talk to patients about their diabetes, their risks, and their foot care can have a huge impact on their understanding, their motivation, and ultimately how well they manage their condition and follow recommendations. There are actually resources available, like tables in the book chapter, that offer specific suggestions for positive and empowering messages that healthcare professionals should consider using. It's about fostering collaboration, not just giving instructions.
To help illustrate all of this, the chapter includes a patient scenario. Can you give us just a quick overview of that case?
Sure. The scenario describes a 51-year-old man with type 2 diabetes and neuropathy who presented with a chronic ulcer on the bottom of his foot, under the first metatarsal head. He was quite active. He had barely palpable pulses, clear signs of LOPS, dry skin, and this persistent ulcer.
Had he tried treatment before?
Yes. Despite trying various offloading methods for about 2 months, the wound just wasn't healing. It was stagnant. X-rays were negative for bone infection. Vascular testing showed slightly decreased blood flow, but the vascular surgeon felt it should be adequate for healing without needing intervention.
So what finally worked?
Ultimately, the patient was treated with weekly or biweekly sharp debridement in the clinic, followed by the application of a total contact cast, TCC. With this aggressive and consistent offloading using the TCC, the wound healed completely within 6 weeks.
What does that case show?
It really highlights several key points: the challenges in treating chronic neuropathic DFUs, the importance of ruling out underlying infection and ischemia, and critically, how effective aggressive and consistent offloading, often with the gold standard TCC, can be in promoting healing, even when other methods have failed.
So to wrap up our deep dive today into diabetic foot ulcers, wow, we've covered a lot. We've seen the truly concerning growing problem of diabetes and the significant rise in DFUs that comes with it.
We have. And we've explored how nerve damage, the neuropathy, and poor circulation, PAD, play such critical roles, along with those changes in the foot structure and biomechanics.
Right. We've highlighted the importance of catching problems early through risk screening and really careful foot exams, as well as thoroughly assessing any wounds that do develop using systems like the UT classification.
And we discussed the many ways to try and prevent ulcers in the first place, including patient education, daily self-checks, appropriate foot care, and the crucial role of therapeutic footwear and insoles for those at high risk.
And then for treatment, we looked at the various options, really emphasizing that absolute necessity of reducing pressure on the ulcer offloading through methods like TCCs or removable walkers, combined with proper debridement and infection management. And we touched on the potential benefits of surgery in certain cases to address the underlying cause.
It's clear, isn't it, that preventing and treating diabetic foot ulcers is a really complex challenge. It truly requires a comprehensive and coordinated effort. This involves not only the healthcare system and a team of different specialists working together, but also, crucially, the active involvement, understanding, and commitment of the patient themselves.
Yeah, it's really through that collaborative approach, that partnership, that we can aim for better outcomes and try to reduce the often devastating consequences of this very serious complication of diabetes.
Well said.
And that brings us to our final thought for you today. Considering the increasing number of people living with diabetes worldwide and the ongoing difficulties we face in truly preventing and effectively treating diabetic foot ulcers, what new and innovative strategies or maybe technological advancements do you think hold the most promise for significantly lessening the impact, the burden of this serious complication in the years to come? It's a big question spanning research, technology, patient engagement, maybe even public health policy, something for you to think about. Thank you so much for joining us for this deep dive. We encourage you to continue exploring this important topic, and of course, to always consult with your healthcare professionals for personalized advice, and if you have any concerns about your own health.